My name's Callum Alexander. I'm the Unscheduled Care Planning and Implementation Manager at NHS Greater Glasgow and Clyde Health Board in Scotland. And I'm introducing you today to the Command Centre, which we established with the MicroStrategy programme and developers. So the Command Centre was built to improve patient care, and it's been integral to how we've done much of the work in the last 12 months, particularly during the pandemic. And its responsiveness is probably one of the things that's helped the senior management team cope with the crisis. And I'll come on to how we've done that in the, later on in the discussion. But first of all, we'll probably take you through the summary of what the Command Centre meant for NHS Greater Glasgow and Clyde. So first of all, it's been a step change. It's allowed us to bring a clarity and transparency to the operational reporting that wasn't there previously. It's allowed us to take what is quite a clunky but data-rich service, which is provided by our electronic health record system, and using MicroStrategy, it's allowed us to create something that's dynamic and much more usable for users. It's also allowed us to create the operational reporting platform, which is, though at its relatively early stage in its development, has enabled the Health Board to already do some pretty innovative and first-in-class type developments, which the rest of the Scottish Health Boards are looking at. And lastly, the joint partnership between MicroStrategy and the Greater Glasgow and Clyde Health Board has meant that we've had a really good working relationship, which means that when something's come up, we've been able to work rapidly and quickly to get a new product developed to help senior teams respond. And that's, like I've said already, that's been really useful during the global pandemic of 2020 and into 2021. So firstly, introducing NHS Greater Glasgow and Clyde Health Board. It's the largest health board in Scotland. It's one of the largest in the UK. It treats people from acute hospital care right through to the primary mental health services, and it covers a population of 1.6 million people. It employs 38,000 staff and has an annual revenue of about 3.2 billion. We operate across 11 main acute sites, and these are just numbers to try and quantify the size and scale of what the Command Centre had to cover. So it had 4,600 acute inpatient beds. And in 2019-20, the numbers that we chose these numbers because 2020 itself was a difficult year to quantify. But in 2019-20, we had about 230,000 emergency admissions, 500,000 emergency attendances. That's the accident emergency, the emergency room, ER, or whatever local variation on emergency department that you guys use. We had 21,000 elective admissions. That's people that come in for surgery. And we had 4,800 admissions into our intensive care units. So our objectives are always that we need to provide safe, high quality care to every patient we treat. As an organisation, we have to turn over every bed every 6 days to have enough capacity to meet the demand that's coming in through the front door. Lastly, across the UK, the NHS across the UK has a patient guarantee. And the patient guarantee is that every patient arriving at the emergency department will be seen, treated, and either admitted or discharged within 4 hours of arrival. That's one of the crucial parameters behind why we needed something that was real time and active, and that's how the Command Centre came about. So NHS GGC, to operate effectively, needs to operate from the patient level right up to the board level. So every patient journey is important to us creating a bed. And as I mentioned before, we need to create a bed. We need to turn over a bed every 6 days. So therefore, every patient journey becomes crucial to making that happen. Individual patient records are recorded into our electronic patient system. That's done by nurses and doctors all throughout the day. And as I said already, that makes us a very data-rich organisation. But we want to build that up from the patient level to create a ward and a department level of analysis, a ward and group level of analysis, a hospital level, and for those of us who work for the board, a board-wide view of it. And that's what the Command Centre was objectives were at the beginning when we set out to start this process. The last thing we needed to do is be able to operate at the individual micro level and the macro level 24/7 a day, 24 hours a day, 365 days a year. So what is the operational reporting Command Centre? It's a new standalone MicroStrategy project. It's allowed us to take data out of our TrackCare electronic system, which is data rich but slow and not very responsive, and takes about 3 days to run a report. And well, it also applies to all GGC NHS hospitals. So we've got consistency of reporting across all of our hospitals, which means that because we're using TrackCare and we're integrating with MicroStrategy, we can create a single source of information across NHS Greater Glasgow and Clyde using MicroStrategy. There we go. It's built on a discrete SQL server database that pulls through information together into a hybrid Snowflake star schema. And I'm saying that, but as an operational manager in the health service, I don't know what that means. But I know that my developer was pretty impressed when we pulled it together, and the BI team certainly were. The project and data warehouse currently focus on the unscheduled care data, but following the success of the unscheduled care team, it's now being explored in the elective. And for those of you who are new to healthcare, unscheduled care is the terminology for an accident, an emergency, or an emergency attendance. And elective is the terminology for people who are planning to come into hospital. And there's a brief description there. The Command Center is a subset of operational reporting, which again was built to separate out our data from what was, when we started this project, a database called Acute, which was a clunky, slow, and difficult to use database. And so we then created the Command Center after we built the operational reporting. So the Command Center reporting includes the emergency department, which is accident emergency, the ER room. And as I've said before, we have to get patients in and out of that area within 4 hours. It covers what is the assessment unit. And to quantify that, that's essentially what we would call a GP referral process, or general practitioner, if you want to put it into layman's terms, and inpatient. So this is probably where the Command Center steps above other dashboards that we've had previously in NHS GGC, and also beyond dashboards that we've seen across other boards. It's the first time people have really been able to create live data in the inpatient environment with all of its different caveats and all of its different data markers. And as we'll get onto the pictures later, you'll see some of the richness and complexity that we're trying to deal with and simplify down into a single view. It also does the bed occupancy and capacity, and this is very much a kind of demand and capacity tables, which shows how many beds we've got, how many are empty, how many we can use, what needs cleaning, what needs turning over. So it's a really useful tool if you're trying to operate 4,600 beds across 11 hospital sites. It gives you that level of granularity at the hospital site and right down to the ward level. So the Command Center also needed to run what we call transaction services, which you guys call transaction services. And what that allows us to do is it allows individual units within the hospital setups to record their data onto the MicroStrategy. And then again, that then means that we have a single source of information and a single answer to the question we're looking for, which might be where are the beds that day, where are the staffing issues. The flexibility of having transaction services attached to the Command Center means that we can have data sourced from TrackCare, and we can also have local users inputting data continuously and giving us the right information at the right time to make the right decisions. So our journey. So we started as an atomized, fragmented, individual reporting process. We were working on Excel and paper. We were working at the local or ward level. We were thinking locally. We were thinking about the beds in our area. We weren't thinking about the whole hospital system. We were debating what the right number was. And often you would get meetings around whether that was the right number or this was the right number. And actually, at the end of the day, what we needed was the number to be agreed upon. So it might be how many beds you've got that day. It might be how many discharges you expect that day. What we needed was to create a common truth, a common source of information, and that means that you can then act on it without having any of the debate going on. So we now live in an environment where we have automated, live and coordinated reporting with a 15-minute refresh on all of our data. So that's a massive transformation, and the amount of clinical time that saves with clinicians, nurses, doctors not having to input data, not having to be asked about bed closures or anything like that is massive, and the impact of that alone, I think, is significant. So introducing what it actually looks like. Here is the product. What you're looking at in front of you is the summary page or the landing page. And you've got your hospital selector on the left, and you've got your link to all the dashboards from there. We wanted to create a main page of all the main KPIs. So if you were just clicking on to look at the Command Center, you could instantly take away the information you needed. You wouldn't necessarily have to engage with the full dashboard, which we will come on to later, of each of these areas. We also tried to keep each of them segmented. So the emergency department has its own set of KPIs, it has its own set of demands, and so it needs to have its own bespoke model. And you can see throughout that, we've got today's admissions, we've got discharges today, we've got current patients in the ED, we've got the number of people waiting for a bed. This is really good time-critical information, and it allows managers and operational leads and clinicians to make decisions from one source. So this is the first of the dashboards. This is the emergency department detailed analysis page. And the way we've tried to make the feel of this is that, again, at this level, which it says, where it says hospital all and location, it's everything you could see in the department. But you could drill that down into the individual resource departments in each of our 4 major ED sites. On the left, you've got the COVID-19 box. So this again shows the innovation and the ability to be flexible that we've had with the command center of MicroStrategy. That wasn't envisaged in 2019, I must stress. And now we have something there that shows us how many patients are on the COVID pathway and how many patients have got a COVID positive test. We've also got how many shielding patients. So these are people that are being shielded and need to be protected from COVID because they're vulnerable due to preconditions. As you work along the top, we've got our core KPIs. And then as you work down, you can see the number of patients who are being triaged. You can see the number of patients who have been discharged already. And you can see things like our performance and our completed episodes. What's really interesting, while we've got that top row that says current patients in department time to triage, these are really good KPIs. But what's really interesting is we've managed to integrate that live 15-minute refresh data with what we have in the bottom left, which is our predicted attendances. Now, predicted attendances means you get a benchmark of what you're expecting to come in the door that day. And that allows staff to plan ahead, think ahead about breaks, think about bringing in extra staff if they know that they're going to get a surge in activity that day. So that's a really useful tool. And it's one that's completely new because of the command center. And it's one that we hope to explore further when we start to move on to using the legacy side of this, which is the legacy database that will come off the command center. The next one is a detailed look at what the triage category is. Now, this is a fantastic ability from the command center. This is the ability to look at each of the emergency departments and see what the acuity of the department is. So the QE there, you can see that you've got patients who are in resus, you've got very urgent, and you've got, if you were to hover over it in live, you would see the number of patients in each of those areas. So for a manager who's trying to manage where the next ambulance should be going at midnight, that ability to see where the acuity of the patients is, where safest to move someone, is invaluable. And it's something that is totally new as a result of this, without having to call round and make a kind of judgment call on the basis of the answers you get on the telephone. The next thing we managed to introduce was the escalation cards. Now, this essentially is, again, talking back to that decision about where the next ambulance goes. This is what the escalation cards are. So you can see here a set of KPIs monitored in a live way, RAG status, so you can see which areas you need to be targeting and which areas are actually running smoothly. I'd like to stress for clarity that the staff to patient ratio at the moment is just because we hadn't entered the staffing data for that day and we didn't have 0 staff, because I think we probably need to stress that measure. The next thing it gives us the ability to do is, and I think this is probably the one that the clinical staff and the staff on the floor find most useful, you're able to drill down to the patient level. Now, we've blurred them out here for confidentiality reasons, but you can see there, you can pull out pieces of information, download it. You can pull out pieces of information just to see the patient level data, and you can start to affect change at the patient level. So here you can say there's someone in the top row who's very urgent. They're in cubicle 13, and they've got time to first assessment, and they're waiting 174 minutes. So we need to be finding that person a bed. We need to be doing something. We need to be actioning that. But we're not just talking about there's a person in ED. We're talking about the named person, where they are, and what we need to do with them. That ability to drill from the kind of location as the Glasgow Royal Infirmary Emergency Department right down to the individual patient means that as a manager working off-site, I can affect change, but as a clinician working in the area, I've got the information to hand that I need. The next one is the assessment unit, and this is similar to the ED, as I said earlier, but this is for the GP assessment pathway. So this is GPs have sent patients up. We've got less information in there because it's much easier to run service in terms of the levels of demand. The acuity of the patients is typically lower. So we've brought down the number of KPIs that we would record and need to look at. But you can see we've got that department activity in the middle. We've got the number of patients that we expect, which is called the GP expects list. We've got those KPIs across the top. And we've got that predicted attendance as well. Again, this has been invaluable, and it's very similar to the ED in terms of its setup. Now we come on to probably the one I I like the most, which is the inpatient analysis. And as I've spoken to you about before, this is because this is something that's totally new. So across the top, you can see the ability to go from the large scale view right down to the individual ward. You've got the hospital, you can take it down to ward groups. So I can look at medicine for the elderly, I can look at surgical wards, I can look at urology, or I can look at the individual ward within them. So I can look at what we call Glasgow Royal Ward 70. If I take you through some of the information we've brought through here, what's interesting about it is what we've mixed and matched in there. So again, there are elements of predictive, real-time, and manual transaction services data here. On the left, we've got our COVID-19 alerts, which are linked back to automatic reporting, which is fantastic. We can do that out of Track Care and bring that through. We've got the emergency admissions. Again, you've got the actual, which is that live data coming off Track Care, integrated with that legacy data, which tells you the predicted historical demand. We've then got what we call the manual data entry for the huddle. So the huddle is probably where this story starts. And the story starts with every day, all of our nursing staff come together 3 times a day to talk about how many beds they have, how much staff they have, what safety concerns they have, and what patients are causing concern or enhanced obs. What we've been able to do is we've been able to make a process whereby we don't record that on Excel and we don't just then store that away in a share drive somewhere. This allows us to go in, enter the data, and bring it through into a live dashboard, which means that that information that's locally held is expanded and acted upon immediately by the team that need to do it. And at a time during COVID, when we've been socially distancing, reducing that amount of inter-staff contact, this has been invaluable in terms of being able to bring data together from a remote setting and still be able to take action. To the right, you've got something called estimated discharge dates, and I would love to try and explain to you in 15 minutes what that is, but I don't think I'm going to be able to. But just know that we're very excited to have it on the dashboard. And to the right, again, we've got that integrated mix of discharges. The other thing I think that's probably really interesting about this section is that we've got in the middle, we've got our daily in and out activity graph. We've then got what we call our bed occupancy by hospital, which we'll probably come on to later. And we've got the bed occupancy by ward. And again, that's a really nice heat map that gives you an instant view of the kind of demands in each area for a bed. And in the bottom right, we've got a very interesting area because this kind of shows, I think, some of the future trends for the command center. It's acting as a single source of information, a kind of like a light for moths to be attracted to. And as a result, we can start to integrate some other dashboards and other data sources. So in the bottom right there, you've got current patient frailty. So current patient frailty is just an assessment that's carried out in NHS hospitals in Scotland. Make sure that everyone over the age of 75 is assessed to make sure that they're not frail, and that if they are, that we do things to make sure that we improve their care and get them to the specialists that they need. So it's a really effective hospital management system, but we're bringing through a frailty dashboard, bringing through that information, and if I wanted to click through, I could go through for a further detail on that. So that level of integration is really exciting because, as I said, everyone's coming to one location, and then from it, they can get into further dashboards and data points. So it's beginning to create a kind of hub for information to come out of it. The last one, and this is one that I've been using non-stop this week, so I'm a bit sad to see it here when I'm doing a presentation, but it's a fantastic tool. And what this is every bed in the hospital set up in the board down to the ward level, and we can see the complement. That's how many beds we've got planned and staffed in that area. You can see how many of them are available. So if they're closed, how they come off, but that shows us how many beds we've got available. You can see our occupancy rate, and then we've got a number of key metrics off the end of that. But the ability to be able to do that is kind of brand new, particularly in such a responsive and dynamic way. On the left-hand side, you'll see all the underlined hospitals. I mean, you can zoom in on an individual hospital and search properly through that way. And you can look across all the wards as well, and you can select by ward group. So I can be looking for a medical bed across hospital sites, for example. Now we come on to the huddle document. I spoke about it earlier. The huddle document is fantastic, and the reason it is because what it allows us to do is kind of take something out of an Excel spreadsheet, which I think are the bane of all, the bane of everyone, and bring them out into the huddle through the command center and bring it out into a kind of live reporting model. What you can see here is taking that Excel spreadsheet, turning it into a live document, and then being able to embed key information around it. So we can see yesterday's EDE attendance and performance figures. Previously, all of that information under the yesterday column would have had to have been manually collected and entered into the Excel spreadsheet at the start of every day before repeating that to everyone who turned up to the meeting. It's a complete waste of time when now we click a button, all the information is immediately there. In the middle, we've got that description. Again, we would usually have had to fill out every piece of information at every ward level to make that happen. Now we just bring it straight through from the command center. And as you can see on the right, you've got tomorrow, and that again is using that predictive one. So this is a fantastic example of reducing staff time, making it accurate, and integrating multiple data sources, which includes manual data uploads, predictive data, historical data, and live data. It's pretty great to see it all in one document, actually. So that probably summarizes what the command center is as an entity. And I think the thing to stress at the end of this is that the command center is at the beginning of its kind of journey. There are lots of things that we're doing with it on a daily basis to improve it and to develop it. Only last week, we were using the operational reporting tool that we talked about at the beginning to develop a new dashboard for monitoring emergency department delays. And this week, we've already made one adaptation. If I take you back to the bed base, this week we had a query about closed beds and finding out more information about them. And working with MicroStrategy and working with the command center, we've already managed to go and add a fourth tab next to by room type called closed beds. And now we've got a granular level of analysis that we never had previously. So what we've managed to build with the command center is a dynamic tool that's flexible, that allows an organization of this scale to affect change really quickly. And one of the things we've never been able to do previously is affect change with our IT systems quickly. There's usually long drawn out processes, and then you don't usually get what you're actually looking for. However, with MicroStrategy and with this command center, that's exactly what we've got. So that kind of brings me to the end of the presentation. I just want to say a special thank you to David Earl, because without him, it really wouldn't have happened, I have to say. Kevin Begbie from NHS Greater Glasgow and Clyde, Jonathan Todd from NHS Greater Glasgow and Clyde, Alison Noonan from the Unscheduled Care team, Gary Campbell, and Paul Matheson, who is one of the private contractors that supported us with this. So thank you very much for listening to my presentation.